Welcome to the Training Stimulus podcast. Today's episode is a solo pod. I'm going to go through a few questions I've had recently, which highlight how we deal with various different injuries and biomechanical issues, which will give you a sense for how to deal with these problems if you have them in your own body or your clients, and also a sense of the principles to solve other injuries. So the first case study we're going to go through is my friend Dave from paddle tennis, and he recently dislocated his shoulder while surfing. He was going over a big wave, basically in an up dog position with his elbows locked out, hit the big wave, and the jarring of the surfboard going into him dislocated his shoulder, going backwards out of the socket, a posterior dislocation. So it's a long story about how he actually got back to shore after that, but he'd made it, he's alive, and is going through the rehab. So we were talking about the general principles of how you might deal with a shoulder dislocation. So there's a few things we need to understand about shoulders before we go into dislocation rehab. There are 4 key elements to a shoulder staying in its place physiologically. So there are 3 obvious ones, which would be the muscles, the tendons, and the ligaments. The 4th one is not so obvious, and this is the capsule. So in the shoulder, we have the ball and socket, or golf ball and the tee, as it's more accurately described. We have tissues that try to centrate the ball in the socket. So they're trying to organize the joint to stay where it should be, so that it has good leverage to create force in whatever movement we're doing. So if we're pushing, we're pulling, we're going vertically, we're going horizontally, or anywhere in between, our body is trying to keep that ball in the right part of the socket relevant to the task. We also have the capsule, which you can think of almost like a suction cup, which has some negative pressure. So it's a bit of a vacuum, which keeps the ball in the socket. When we have a dislocation, that suction is lost and you can never get it back. It's not a huge contributor to keeping the ball in the socket, but it is one of the factors. So we need to bear in mind that that will be gone forever unless you get some sort of vacuum pump to create that negative pressure again once it's sealed in the right place. So we've just got the other 3 elements to work with. So when we've had a dislocation, the possible outcomes for the other tissues could be that the ligaments may have become overstretched, so they're now loose. And because they're non-contractile, again, there's not that much we can do with that unless we get them surgically reattached, much like you'd have a ACL reconstruction or something along those lines to create more passive stability. Next, we have the tendons. These may have been torn or stretched. They're not as well capillarized as muscles, so the rate of healing is much slower. However, we have ways of making tendons stronger, which are generally more long-term projects. And then we have the muscles, which we're much more familiar with, and we have several muscles around the shoulder, which can help to keep the shoulder in position. So in terms of a process for getting somebody's shoulder back to full function after a dislocation, obviously we need to get the shoulder back in the right place. So Dave is lucky enough to go to hospital and get it put back and ensure there's no other tissues trapped between the ball and the socket, which would be pretty painful, and you'd know about it if that was the case. Then we've got to go about getting the shoulder back to function. Obviously, there's going to be some pain and inflammation to deal with. But from a biomechanical perspective, once we're able to start using the shoulder again, we have a few dimensions that we need to work on. So we can think of range of motion, stability, and strength, as well as the ability to tolerate the forces that are going to be imposed in it specific to the individual. So the sports that they play, for example. So for the stability and mobility, there's always a bit of a dance between these two, because if we create maximum stability, we're going to create a shoulder that doesn't move. And if we create maximum mobility, we're going to have a hypermobile shoulder, which is going to be unstable and too loose. which following a dislocation, the thing that we're trying to avoid is another dislocation. So we don't want a loose and weak shoulder that's likely to fall out of position again. So my preference for rehabbing dislocated shoulders is to have a big emphasis on stability and only pursue range of motion as far as you feel safe and stable. So it's a bit of a, like I say, a bit of a dance, bit of an arms race where we don't want one movement quality to get too far ahead of the other. You don't want a super stiff and stable shoulder that has zero range of motion, and you don't want to chase pure range of motion without any respect for stability and end up having an awesome overhead position, but a shoulder that's just going to fall out every time you sneeze. So think about your stability from the angle of angles and different directions. So obviously Dave dislocated his in a kind of plank position, hands out in front of him, and had a posterior dislocation. So the goal with any rehab journey like this is for him to be able to withstand the mechanism of injury that happened the first time around. So we want him to be able to be on a surfboard, have a big wave hit him, and not worry about that shoulder coming out the back of the socket. So everything we do in the rehab journey is moving him in that direction. So we need to find a dose of that stimulus that he can tolerate and recover from and adapt positively without re-aggravating the issues. So from a stability point of view, we want to get him comfortable centrating that shoulder in the socket in other directions, because the one that injured him is the last one we're going to work on because it carries the most risk and is probably in his head the riskiest position. So we don't want to jump straight in at the deep end. So I would recommend going in with things like side planks, maybe even crab walks, where we are asking the shoulder to stay in position and get stable, but without pushing into the direction where damage occurred or where the dislocation occurred. Once he has got a baseline level of stability, and like any exercise, we need to try to pitch it at a level we know he can do successfully. So if we're asking him to do full side planks on the hand in a starfish with lots of motion, that's probably going to be too much immediately post dislocation. So having him lying on his side on his hip with just his elbow, doing short exposures, microdosing the stimulus to a level where he can start to successfully execute the exercise and build some positive momentum would be a great way to begin that journey. And like any progressive overload in the gym, we just want to slowly ask for a little bit more each session. Because it's not hugely demanding from a muscle perspective, we can do this a little bit more often. Like you can do small doses of side planks 3, 5, even 7 days a week and be guided by how the body recovers. If you feel beat up and sore, then you might need a little bit of a rest. Just sensible progression in this way is the best way to go. So once we've got that stability, we can start pairing that with some range of motion work, always bearing in mind that stability is the first priority. Because of the dislocation, we want the athlete to feel secure in their shoulder more than we want them to race towards full range of motion, because like I say, that dislocation risk is the one that we're trying to avoid the most. So standard stretches, as if you've consumed any of my content, you'll know I'm a big fan of pairing shoulder motions with thoracic spine motion as well. So reaches across the body with a twist of the spine, reaches up and overhead with a lateral flexion of the spine, side bending both ways, rotating both ways, will help the musculature of the shoulder lengthen and activate to a greater extent than if you're just doing really targeted shoulder stretches, which are not the full story when it comes to range of motion and shoulder positions. So I would go through this dance, leveling up the stability and then bringing the mobility alongside it. And you can pair these two movement qualities really well together through toe taps. So if you go into a plank position, reaching the hands down towards the feet to get a stretch into a simulated overhead position whilst also working the shoulder stability at the same time. One of the big principles we talk about all the time at the Training Stimulus is this concept of Mo stability, which was coined by Gary Gray. And it's the idea that mobility and stability are interdependent. So you can only improve your mobility insofar as your stability allows. If you're super unstable, your body will shut down your range of motion. So you'll be perceived to have less mobility because the body doesn't feel safe. So if our goal is to restore range of motion, we need to make the body feel safe through giving it adequate stability to go alongside the range of motion that we're working on. And by working on them both at the same time, it's a really great way to ensure that they level up roughly together rather than doing some really pure targeted stretching and flexibility work in the absence of stability work. So we can start off, Dave, with his side planks, his crab walks, then get into some quadruped work where he's on hands and knees doing reaches in various different directions to get that first exposure to driving the shoulder into the backside of the socket. And once he's comfortable with those, classic progressions of going into a full plank and starting to expose the shoulder to dynamic stability rather than staying in roughly the same position throughout the exercise. So things like crawling are excellent as well. And another classic exercise that works really well for dislocations would be Turkish get-ups, where we are now exposing the shoulder to a stabilization demand whilst taking it through a variety of positions, including, pushing it out in front. So this is what I would consider like the foundations of good shoulder stability. However, as I mentioned at the start, the end goal is to have him back surfing and confident to get hit by a big wave and that his shoulder's not going to fall out. So we need to get him to recreate the dynamic stability and reactive stability to those sorts of incidents. So this means something more plyometric with some form of ground contact or ground reaction. So what I suggested to him is to do some kneeling plyometric push-ups where he is at first pushing off the ground and jumping up onto a plate. So he's not actually landing that hard because he's jumping upwards compared to jumping down from a plate to the floor, which would be a stronger stimulus. So in that way, he's getting that jolt stimulus that he would get from his surfboard being hit by a wave, and he can microdose that at a level of intensity and a volume number of reps that his body can tolerate, and he'll start to adapt to deal with those forces, obviously at a low level before gradually ramping it up and increasing the intensity of those ground contacts. The end goal for this would be, well, one of the end goals we could work towards would be doing full plank drop down push-ups. So he could be on a plate and he's dropping down into a locked elbow position and getting that jolt in the shoulder, and he's absolutely fine to soak it up through his hands, arms, shoulders, but also his anterior core, exactly like he would be if he was arching up on his surfboard. So the principles I want to illustrate with this example are how we can break down the mechanism of injury and create a rehab journey which reverse engineers the signal, the stimulus, the movement quality that caused the issue in the first place. So that arms outstretched, posterior dislocation, we are working backwards from that to give the body a stimulus to adapt to be strong and ready and able to deal with that should it happen again in the future. With these sorts of contact injuries, it's almost more straightforward because we know what went wrong, where the weakness was, and what we need to bolster the body against in future to ensure he will be robust enough to do his sport as he wants, and the chance of re-injury is reduced as much as we can. And we essentially pitch at the level of stimulus that the body can handle and successfully adapt towards, and build up that movement quality in ways that replicate without fully recreating the dislocation stimulus. And this can be applied to absolutely all injuries of this sort, that we can condition the body to be able to withstand the thing that hurt it in the first place. So that's number one, shoulder dislocations. Number two is from a great conversation I had with a couple I met here in Bali, Victor, an osteo, and his girlfriend, Ivona. And we're talking about some pain Ivona was experiencing from running. So she was getting lateral hip pain, so pain on the outside of the hips. And we were trying to figure out why that might have happened. And I just want to talk you through the thought process so we can get some good clues as to identifying the root cause, but also what we might do to address it. So when somebody's getting a new pain like this from a specific movement or sport, we're thinking those tissues have been overloaded. So why are her lateral hips getting worked more than is ideal? And when we're thinking overload, there are two types of overload. So there is a pure load management issue where you're literally just doing too much too soon. And then there is a biomechanical overload. So the way that your body is moving is putting more stress than is ideal in that specific body part or tissue. In most cases, it's a little bit of both, and we can address both to cover most cases. So for load management, the checklist we're going to run through is look at the volume, like how much is she running at the moment? How much did she run last week, or has she been running recently? Has there been a big spike in her running volume? And she said that she's increased her running. She's added about 4 kilometers per week, which might not seem like loads to a runner, but she was doing 16 kilometers a week before. So it's actually a 25% increase in volume. So if you think about how many footsteps you take per kilometer, it's a lot. And adding 4 extra kilometers per week is actually a lot of extra reps. So the body is doing a lot more volume than it has been before. So we can consider that a spike in volume. As a general rule of thumb, we want to aim for no more than about a 10% increase in volume, pure volume, or intensity. So adding weight or speed per week. Even that is quite fast if you tot it up over a long period of time. So if we're exceeding that, then we can think we might tidy this up by pure load management and dialing things back for a period of time. The other thing we can do with load management is how is that volume spread over the week. So if you're running 2 8-kilometer runs and 2 4-kilometer runs per week to hit that 20K, for example, you could go 8-8-5-5 or 7-7-6-6, which means each individual run isn't digging as deep into your threshold. So you're much less likely to tip over into overload for a specific tissue, and you're less likely to aggravate the issue on any singular run. You'll also recover sooner before your next run as well. So having a flatter spread of your kilometers over the week can help with load management, even if you don't reduce the volume. If you think about what would be most taxing on the body, if you're running 20K a week, it would be to run 20K on one day and 0K the rest of the week. That's obviously going to give you the greatest chance of overdoing it. So if you were to divide that by 7 and do just under 3 kilometers per day, it wouldn't feel like much stress on the body, but you're still accumulating the same number of kilometers per week. So the closer to running daily you go, generally the lower the incidence of load management related injuries. But obviously if you're just doing too much too soon, you're doing too much too soon, and that needs to be addressed. Next, we can look into the biomechanical reasons for why the lateral hip is doing too much work. So the lateral hip, the primary muscles we're thinking about, or the primary muscle we would be thinking about is the glute med, based on symptoms. And we know the glute med lengthens with hip adduction. So that either means the knee is moving inwards too much, creating length and load on the outside of the hip, or the hip is moving outwards too much, also creating length and load on the outside of the hip, the symptomatic area. So there's several reasons that could be causing either the knee to move in or the hip to move out. And we would want to do an investigation to figure out which one of those is happening so that we can address that to stop the excessive motion, which would then reduce the load on the lateral hip and the overuse of that glute med. So typical things that we might see to cause this would be foot rolling in for, again, a variety of reasons. People might call this overpronation or excessive eversion. Too much tibial internal rotation can be related to this as well. And the way to think about this is the foot is falling in, collapsing inwards. Your knees are almost rubbing together when you run. So we create that length and load through the lateral tissues of the hip. So that's one way it could happen. Another way it could happen would be the hip going out. So if you saw somebody's hips shifting side to side a lot when they're running, this obviously isn't ideal. We're trying to go forwards. We're not trying to go sideways. So if you saw that in their run pattern or their gait mechanics, that suggests that either their lateral hip is too loose, so that glute med actually isn't decelerating the hip shift to the side soon enough, which would be a lateral hip stability issue. We want to load that tissue, create tension and stability to stop the hips shifting so much. Or the cool and complicated one we call a cross-body compensation pattern, where the opposite side adductor might also not be doing enough to prevent those hips shifting to the side. So let me break that down a little bit further. If you imagine your right foot is forwards and your hips are shifting to the right more than ideal, obviously the outside of the right hip is going to get lengthened and loaded and should be bringing back that hip towards over the foot. However, if it's not doing that, the other option we have is that the opposite leg, so the left leg's adductor, could also decelerate the hips or the pelvis shifting to the right as we go into back leg, left leg, hip abduction. So we're getting length through that adductor. And if it's not biting, it's not providing tension and decelerating that hip shift over to the right, then too much work is going to be done by the outside of the right hip. So this is a cross-body partnership, or it could be a cross-body compensation pattern, because those two work together to do a similar function in that they're both trying to decelerate the pelvis shifting over to the right and bring it back towards center. So if the rear leg adductor is not doing enough, then the right lateral hip could be doing too much. So this is one plausible mechanism for creating the overload in the lateral hips, is that the adductors are not doing enough when they're the rear leg in the run cycle. So this is a useful piece of information paired with something that Ivona mentioned earlier in the conversation, is that she's hypermobile. So she does a lot of yoga and is very flexible, which is a classic risk factor for these types of issues, in that if somebody has very flexible adductors, like a rubber band, if you have a long, loose rubber band, you need to stretch it more before it provides tension and elasticity. So if we imagine in running, especially if you don't have a long stride length, those adductors are probably not going to be providing much tension because the legs are never that far apart compared to doing a pancake stretch or a sumo squat, something along those lines. So We would obviously need to do some detailed testing to figure out which of these ones was the biggest red flag. Maybe all of them are partially true. And then we would need to select exercises to address them. So working on pronation and supination mechanics in the foot to create an appropriate amount of foot and ankle stiffness, working on some plyometrics to stop that foot collapsing inwards. We would also want to strengthen and stabilize that lateral hip. However, the thing we need to watch out for here is that those muscles are already doing too much. So stabilizing and strengthening them could contribute to the overload. So it might not be something we do until the issue has calmed down. Then the third option is creating more tension in the opposite side adductor. So we could do this with side lunge variations, or I like to use train track walking lunges for this. It's basically wide feet walking lunges so that we are mimicking walking and running mechanics, and we can exaggerate the demand on the rear leg adductor. We can add in a lean over the rear leg as well. You'll feel a big stretch in the groin, and we're basically teaching that muscle that it needs to do some work to stop the hips shifting over to the right and gradually work that back towards a normal width and to run mechanics. But the goal for all of these exercises is that we reduce the excessive hip adduction through the foot, through the hip, or through the adductors, so that those tissues don't do too much when she's just doing her normal run mechanics. So case number 3 is scoliosis. So this was from a chat with Mr. Lewis Fern, who's been a case number 3 is scoliosis. So this comes from a chat with Mr. Lewis Ferns, who's been on a couple of episodes as a guest so far. And we're talking about one of his clients who has scoliosis, which, for those of you not familiar, is a curvature of the spine in a left to right, generally, or right to left in the frontal plane, like a sideways curvature of the spine into kind of like an S shape. So it's normal to have an S shape if you're looking from the side, but if you're looking from the front or the back, then it's less normal, though still very common to some extent. So most people will have a natural scoliosis in that they prefer to side bend one way more than the other because we are asymmetric beings. However, if it gets excessive, then this can cause problems, creating excessive compression on one side. And in some cases, people will often have surgery to fuse their spine straight using metal rods, which then removes all lateral motion from the spine or motion in all dimensions, all 3Ds, which is another discussion for another time, but it's a very intrusive surgery and requires a long period of time to heal because you can't move your back at all. So we obviously want to avoid that at all costs. And one of the things that doesn't get talked about enough is that scoliosis can be changed through movement. So the classic symptoms somebody would present with if scoliotic are that they're very tight on one side. So side bending one way will generally be a lot harder than the other way, and they'll be loose on the other side. So they might struggle to activate muscles, and there'll usually be a big strength discrepancy in that the short side, the tight side is nice and strong, and then the loose side is mobile but struggles to generate force. And Lewis has been getting some great success with this client, working on his thoracic spine mobility and doing his muscle imbalance assessment protocols, and the athlete felt improvement. However, they regressed as they're training towards an event which has a 5-rep max pull-up test. And we're talking about the tension between optimal mechanics and maximal output. So because this athlete is competing, there is a trade-off between getting his body to move as well as possible to give him maximum movement options to alleviate the dysfunction in his body versus getting him ready for the competition to lift as heavy as possible in this 5-rep max weighted pull-up test. The reason that is that the body will always do or will always use the strategy it knows best when it needs maximum output or it's fatigued. It's like when you're in a desperate situation, you just fall back on the thing that you're most familiar with. And this isn't necessarily a problem unless it is a problem and your pattern feeds your injury or dysfunction. So if we think about this pull-up test, if this athlete has scoliosis, then they're trying to max out their pull-up. They're going to lean towards the strong and tight side, which is going to further strengthen and tighten that tight side and feed the scoliosis rather than even it out. And this is one of the drawbacks of doing lots of bilateral loading, is that the strong side continues to get stronger because it does more of the work. On a very basic level, this is one of the reasons why unilateral training is great, is because you have less opportunity for one side to do the work for the other. There still is an opportunity in many movements, but it's much reduced compared to going super heavy in bilateral. So when dealing with this, we need to make a decision with the athlete in terms of priorities. If they have a competition coming up soon, then it might be worth the short-term pain to feed the dysfunction slightly and just lift as heavy as possible, even if it's a bit ugly and asymmetrical, versus the long-term journey of trying to even out the scoliosis and bring up the strength of the other side. Like long-term, if the weak side started contributing more, their 5-rep max would be better overall. But short term, trying to create a more symmetrical pull-up just before competition will likely reduce the power output because we're prioritizing symmetry over absolute output. Say the right side is the strong side. We want that to be as strong as possible, as well as the left side being as strong as possible. So if we don't have much time to change the movement pattern, we want to stick with the one that we know works and just squeeze as much out of it as possible, develop a lot of skill and repetitions in that pull-up pattern that's going to be tested, rather than doing tons of single arm pulling. Like I say, long term, doing loads of single arm pulling will result in a stronger pull overall, but short term, to peak for the competition, he needs to get very comfortable and familiar doing the pattern that's going to be tested. If you've competed in any sport or fitness competitions like this, you'll know when you feel a bit rusty, the movement just feels a little bit clunky, and particularly with strength sports, you're going to miss out on a few percent just because you're not moving as efficiently as you could be. Whereas if you're in a groove of playing the sport regularly, then it's almost like gravity. You just move towards the right pattern through instinct, and the activation is much better. You'll get better recruitment of your target muscles, and the movement just feels smooth and natural. And that's generally when you can perform your best, provided you're sufficiently recovered. So I think the takeaway from this case study is just be aware of the trade-offs you're making. Are you looking to move as well as possible long term and are happy to let your performance take a dip short term for long-term gains? Or are you in a position where you need to peak right now and you're willing to sacrifice a little bit of pain, you're willing to sacrifice a little bit of discomfort, and setting yourself back in terms of ideal mechanics to get a performance out of yourself sooner than earlier, and then you can pick up the pieces later on. And there's no right answers. It's a personal preference thing. Like, how important is the competition to you versus would you rather perform a little bit worse today to perform better in future by ironing out that imbalance? So yeah, I think that's enough for today. Would love to hear what you think about the dislocations, the lateral hip pain, and the scoliosis. If you have any questions on these issues, or you want to hear other topics covered, please drop them in the comments below. I've just learned that Spotify lets you comment as well as YouTube, which I should probably have already known. But please do get in touch, as we want this podcast to be as helpful as possible and as relevant to you guys, the listeners. But thank you for your time, guys. And as always, if you are a movement professional or rehab professional, physio, osteo, chiro, CrossFit coach, personal trainer, please do check out thetrainingstimulus.com, where you can join our school community and get access to a whole host of free educational materials, which will help you get better results for your clients and patients. But thank you again for your time, guys, and we'll see you next week.